Well, good afternoon, everybody. My name is Eric Yeager, and we're going to be talking today about managing the agitated patients, avoiding the major pitfalls of physical and chemical restraint. Thank you all for coming. I hope you get value out of this conversation. And I really am hopeful, even though we're in this gigantic lecture hall, that we can make it into a bit of a conversation, because I think that's important here. As I mentioned, my name is Eric Yeager. I'm an RSI paramedic and EMS educator from Exeter, New Hampshire. I work at a hospital ED up there, where I both work in the emergency department and I'm an intercept paramedic serving roughly 20 communities that we respond to. I'm also an attorney. I did that for many years before becoming a paramedic, representing healthcare clients in Boston. And I went to MIT for computer science before that. Yes, I can't decide what I want to be when I grow up. So let's go on. We need to have a conversation about the risk of death in the management of agitated patients. And my plan is to challenge some of the assumptions and dogma we hold about the risks involved in these patients. I'm not going to pretend. I'm talking this afternoon about core airway maneuvers. And when I talk about that, I'm pretty confident I know the right answers, not because I'm all that and then some, but because we've got a lot of high quality research. We have experts who can give us guidance. This topic, not so much. This is a challenging topic where we don't really know what the answers are, and it's part of why I call it a conversation. But I certainly have questions. I'm going to share some of those questions with you today and share some of what we do know about the correct way to manage these patients. Let's define what we're talking about. We're talking about situations involving physical restraint by law enforcement or EMS. Examples might be someone arrested by the police, someone suffering a psychiatric emergency where we're responding to provide care, a patient shirtless walking down the street exhibiting bizarre behavior who's on meth or cocaine or something else. I am going to be discussing some incidents where things went wrong and patients died. I want to be super clear when I talk about this topic. I'll show you some of these videos and I hear people say, oh, those guys screwed up. Those guys were idiots. They were negligent. We wouldn't do that. It's not for me or us to judge what happened in these incidents. We only have a piece of video perhaps or a patient care report. I'm not here to judge those paramedics and those police officers. Instead, I really want to ask the question, how do we prevent it from happening in the future? How do I keep all of you and the agencies where you work off the 6 o'clock news, out of the limelight of an unwanted investigation? And how do you keep your patients safe? I'm going to start by sharing with you a story about James Britt. James Britt died, unfortunately, in September 2019 in Mount Pleasant, South Carolina. By all accounts, he was a nice, pleasant gentleman, a 50-year-old travel lift operator at the local boatyard. He stopped to change a flat tire one day. A South Carolina police officer stopped to check that he was okay, discovered he was intoxicated, called additional police officers. So initially, Mr. Britt was very compliant, very polite, yes ma'am, no ma'am. Unfortunately, when more police officers arrived and a field sobriety test was conducted, Mr. Britt was told, sir, you're going to be arrested for driving under the influence and your car is going to be impounded. And not surprisingly, he got upset. He kind of went a little crazy for a moment. They took him to the ground, and I'm going to show you what ensued. You'll see Mr. Britt there on the ground being held down, police officers, and in short order you'll see a paramedic give Mr. Britt ketamine.
I didn't do this wrong. I swear to God, I'm not hurting nobody. God damn it.
Let's get a good arm.
Please.
Good touch.
Please.
That's right here.
I swear to God, I'm not going to do that.
Go ahead and pop out. Pop out. Pop out.
Oh, you got it right there.
There you go. We're right here.
Please, God damn it.
Huh?
Please.
Yeah.
Ah.
We good.
All right. Just don't stab me. Thank you, sir.
That's the ketamine, 500 milligrams.
It's a little medicine to make you just have a good time.
Please.
There you go. Safety lock.
Stay down.
Give us.
I didn't do nothing.
Here, I got it. Let me rub it in.
Please let me go. Please let me go.
We will. Just
Please
relax.
let me go.
Just relax, okay?
Give
Give us just another minute or two.
You're good.
It'll start working, okay?
Try to keep him from spitting on anybody, you know? What appears that he has is just a little gash on his eye.
Okay. It's okay, buddy. Hey, listen, Mr. Britt, just relax. Just relax, buddy.
This is wrong.
No, it's not. No, it's not. Listen, it's for everybody's safety, buddy. It's for everybody's safety. Okay? Everybody's safety. All right, just relax, okay? No, you're not gonna die. You're not gonna die, buddy. It's okay. It's okay. All right, listen. Hey, buddy, Mr. Britt. You allergic to any medicine? Mr. Britt. Mr. Britt, are you...
Please let me go.
Mr. Britt.
This is wrong.
Mr. Britt.
You
Are you...
fuckers.
Hey, look.
I can't win.
Hey,
I swear to God, I'm not gonna do that.
listen, are you allergic to anything?
No.
So I'm going to pause right there for just a second. I already have some concerns. I usually like to do this in an interactive way, but James Britt is being restrained on the ground, and I think a legitimate question is, at that moment where the paramedic administers the ketamine, is he a threat to himself or others? You can't fully see, but his arms are handcuffed behind his back, his feet are shackled. And I think there was a point in time where he said to paramedics, anytime someone is physically restrained and at all agitated, you should also chemically restrain them for your safety. And in fact, you hear the paramedics say that, except I think we need to ask the question whether that's always the case, and specifically is the case here. Other concerns about James Britt: he is obese, he is intoxicated, he's lying on the ground, and if you hear his breathing, it already sounds sonorous. He already sounds like he's struggling a little bit to get an adequate tidal volume to avoid becoming, and we don't know, but I suspect he's slowly becoming more hypoxic and acidotic as he lays there. Another thing we see in the video already, you heard him ask after giving the ketamine, Mr. Britt, are you allergic to anything? Mr. Britt, you'll hear him say, do you take any medications? When was the right time to ask those questions? Before. EMS 101 says when we show up on scene, the first thing we do is conduct an assessment before we go on to treat the patient, and in particular before we go on to treat them with a powerful sedative drug. Let's go on.
All right. Do you take any medicine?
Let me go.
No. Listen.
Yeah, dude.
What do you take?
High blood pressure.
What medicine do you take?
Lisinopril.
All right.
I'm going to go on. This is the next part. After he's given the ketamine, it's 500 milligrams. He slowly becomes less responsive. They decide at this point that they can safely move him up onto the stretcher. And I want you to watch and listen carefully. Watch his breathing. Listen to what people say.
Yeah. We got the mega mover. All right. We're there. We're almost there.
All right.
Secure his head. Secure
I got space. I got space.
We just need to, we can lift log rolling onto his back, and then that will help us a little bit more. There we go. Just put it right there.
Towards. Away from 17. Ready?
Ready
1,
to go?
2, 3. There we go. Watch your head. Watch your head right there. Alrighty.
All right. Grab a handle.
Enough of us. Ready? Oh yeah.
All right. Transfer over. Transfer over. Move to the side so we can. All right. Everybody okay here? All right. That handcuff over there. Okay.
Ready? Roll back towards Rayleigh for a second. Oh, never mind. We got it. You want to keep it as 2? Yeah.
He's out. He's out now. So.
Yeah. So want to double that?
Oh, sorry.
107, are y'all not by the lawn and garden section?
Anybody heard on thing? Making sure. Good, sir? I'm good. You sure? Yeah. Okay. All right. Hang on. Let's There we go.
Hello, confirmed. Mondo Crossing. You said it'll step outside to meet with y'all in about 2 minutes.
Alright. There you go.
Incident 5.
Did everybody see how he's breathing there? That's agonal breathing right there that we typically associate with cardiac arrest. The paramedic seems to notice, and again, I want to be super clear, I'm not criticizing these paramedics or these law enforcement officers. They're operating under difficult conditions. I don't know their training, their supervision, their protocols. This is purely for us to look at and be able to talk about how we might manage a similar situation differently. But you notice Mr. Britt now begins to have vaginal respirations. And he's got an honorable breather mask on, but I don't see any other resuscitation equipment there. I don't see any monitoring equipment. And just before that happened, where the paramedic looked down and he was agonal breathing, the paramedic was talking with the police officers. He was chatting with them about whether they were coming over, whether anyone else needed to be evaluated. And I would argue that where his focus needs to be, once he's administered a powerful sedative, is 100% on that patient. Listen carefully now.
And we'll kind of take it nice and easy over there to East Cooper on the way over. And we'll see y'all there. I don't think he's gonna get up. So I don't think I'll need anybody to ride unless y'all need somebody to ride. No, definitely. He'll follow behind. Okay. He's not breathing. Okay. Oh yeah, he's good. All right. He ain't getting up. If he gets up, we got problems.
Have we requested a tow for this yet?
He hasn't taken a breath in 30 seconds. That's it.
He hasn't taken a breath in 30 seconds. One of the police officers.
Still no breath.
Still no breath. To get in the back, they immediately begin resuscitation. And here's the last part.
115 copy. Unit 10-4 here, officer.
He's not muted. After I told him today, I came across there, but I didn't get his impact or anything. As soon as he got down on the ground. So this is, I think this is ketamine.
One of the police officers says this is the ketamine. I hear sound in the background. You recognize that sound? That sound is CPR. Whoop, sorry. That sound is CPR being performed. Mr. Britt is now in cardiac arrest. He's resuscitated, they obtain ROSC, they transport him to the hospital, and he dies a week or two later of anoxic brain injury. This, I would argue, is a tragedy for James Britt and for his family, but it's also devastating for the EMS providers and law enforcement officers involved. This is Elijah McLean. Elijah McLean died in very similar circumstances 1 month before James Britt in Aurora, Colorado. He was walking down the street, home from a convenience store where he'd bought a couple of items. Someone dialed 911 to report a suspicious person and literally says on the call, I don't know if he's good or if he's bad. The police stop Mr. McLean, and they end up in a wrestling match with him. 911 EMS is called, EMS shows up, they inject him with ketamine. He's held on the ground for 2 more minutes. When they get him up, they say he's unconscious. In the back of the ambulance, he goes into cardiac arrest and dies a short time later from anoxic brain injury. The headline I have up there is from the New York Times from a couple of years ago. 3 officers and 2 paramedics criminally charged in Elijah McLean's death. That's a pretty frightening headline for me to read as an EMS provider. As it turns out, the 3 officers have already stood trial just recently. 2 of them were acquitted and 1 of them found guilty. And the 2 paramedics are just going on trial now. And these folks are not alone.
After months spent examining autopsy reports, court filings, and news stories, we found example after example of law enforcement agencies largely ignoring the warnings.
All the way down.
We know of at least 107 deaths, 7 in Texas, that followed prone restraint since 2010. There are likely many more. We found families impacted by loss in places like Louisiana, North Carolina, California, and in our own backyard, North Texas.
It's just going to continue until somebody puts a stop to it.
And in the video, you heard them refer to restraint and specifically to prone restraint, right? And we're going to come back to that. But prone restraint is at the heart of some of these issues. want to talk for a moment about excited delirium. For many years, we've talked about excited delirium as the cause of death of many deaths in custody. And in fact, in some of the deaths I've already shared with you, excited delirium has been brought up as a potential cause of death. There's a real question, though, as to whether it's a real condition. In the past, the American College of Emergency Physicians, that sets a lot of the policy for EMS, and the National Association of EMS Physicians recognized excited delirium as a valid diagnosis. More recently, however, all major relevant medical organizations have rejected excited delirium. The American Medical Association, the American Psychiatric Association, the National Association of Medical Examiners, and the College of American Pathologists have said it should be no longer listed as a cause of death on death certificates or on autopsy reports. And just within the last few months, the American College of Emergency Physicians formally rejected the use of excited delirium as a diagnosis. The American Medical Association produced a report a couple of years ago that looked at this and said excited delirium and potentially fatal restraint are inextricably interwoven. Restraint was described in 90% of all so-called excited delirium deaths. There is no evidence, they said, to support excited delirium as a cause of death in the absence of restraint. It's been rebranded. People often say to me, Eric, what do we call it? Because 100% we encounter agitated patients in delirium all the time. So if that occurs, you could call it hyperactive delirium with severe agitation, but that's not really the point. With regard to both James Britt and Elijah McClain, neither one of them was at all agitated until they were restrained by police. And that's not, I don't know necessarily what excited delirium is or what hyperactive delirium is all the time, but I know for sure that neither Elijah McClain nor James Britt were exhibiting any kind of delirium or agitation before they were restrained by police. So the real question in the end is what killed James Britt and so many others in custody. Let's get back to Elijah McClain. This is Dr. Melissa Costello. I'm going to share with you she was on a blue ribbon panel that was asked by the city of Aurora to look into Elijah McClain's death. And I'm going to share with you some thoughts from Page, Wolfberg, and Worth, a national EMS law firm. I want to go back. Dr. Costello said she's concerned there was a failure to take steps to keep the patient, the officers, and medical personnel safe, and I like her focus. Yes, I'm focused on patient safety, but she's also concerned about the officers and the medical personnel. One of the questions that comes up and came up in the case of Elijah McClain is, when does someone who's agitated and being restrained by police become a patient? She said, Dr. Costello said, there's a widespread sense the patient is not a patient until the police say they are. This represents a problem of both policy and culture. The lack of clarity regarding which department is in control and when has the potential to create major problems for patient care. Unfortunately, the approach the patient is not a patient until the police say they are is not uncommon in EMS agencies nationwide. However, PWW said EMS cannot just sit back and complacently wait until the police say it's okay to assess a patient. And let me be crystal clear. If it wasn't clear before, when you respond in response to 911 and you step off that piece of apparatus, that individual is your patient. They may be in the custody of police when you arrive, and the police might not immediately turn that individual over to you, but if you show up on scene and they're restraining a patient in an unsafe manner, you have a duty to attempt to intervene. And I for sure don't mean to accost the police officers. I mean to interact with them professionally the way we always do. Hey, Sarge, can we get up off him? I'm worried about his breathing. Hey, Sarge, can we roll him up on his side? I'm worried about his breathing. How can we improve? PWW said we should work with law enforcement to develop a procedure clearly identifying the roles of law enforcement and EMS. We should train and train and train using role play and mock case scenarios. We do that for PALS, we do it for ACLS. Why aren't we doing it for these emergencies as well? And they also suggested we practice communication skills to intervene effectively with police. Dr. Costello addressed the question, what should EMS providers have done after gaining access to Elijah McClain? They should have initiated at least a primary assessment and conducted a brief hands-on evaluation, fingerstick glucose, peripheral pulses, etc. Now, Dr. Costello is not an idiot. She knows that Elijah McClain was agitated, that they had him restrained on the ground, that they were wrestling with him, and so couldn't necessarily perform a full assessment the way we otherwise might. And yet, I got to tell you, it's still EMS 101. You show up on scene, someone's agitated, you need to ask yourself a question. Why are they agitated? Could they be a diabetic? Could they have head trauma? Could something else be going on that's causing their agitation? And you might not be able to conduct a full assessment, but you need to conduct whatever assessment you can. You need to bring over the monitor, ask about history, conduct an assessment. And something seems to happen to us when we respond to these agitated patients where we forget that part of EMS 101. What needs to be in place before proceeding with sedation? All equipment required for sedation should have been present and available beside the patient. Aurora Fire could not locate, for example, their end-tidal CO2 probe. In the minutes preceding his cardiac arrest, end-tidal CO2 may have allowed EMS personnel to anticipate and possibly even prevent Mr. McClain's precipitous decline. In that video I showed you with James Britt, there was no monitor there on scene. And because they hadn't brought the monitor over to do their initial assessment, that cascaded into the monitor not being there after they've administered the ketamine to continue to monitor Mr. Britt and to support him once he began to precipitously decline. So what about the ketamine? We like ketamine for the management of severely agitated patients. There are other agents that we can choose, and you should give consideration to using the right agent for the right patient, but for the severely agitated patient, ketamine actually works well, in part because it works so rapidly. It usually doesn't cause hypotension. It usually doesn't cause hypoventilation, but there are important caveats. When we rolled out ketamine to the EMS community, we probably didn't do an adequate job warning people of the risks. If I gave everybody in the room right now ketamine, 500 milligrams of ketamine, you'd all just go to sleep. And if I whispered sweet nothings in your ear before you passed out, you'd all wake up and tell me you'd had a wonderful dream, and nobody would die. It's not truly about the ketamine. However, if I take a hypoxic acidotic patient who might be intoxicated, might be obese, might be being held on the ground in a manner that doesn't allow them to expand their chest well enough to get adequate tidal volume, and I give that individual ketamine, and I take away that conscious piece of sympathetic drive that's pushing James Britt to get up off the ground so that he can take a breath. Once I eliminate that, that protective mechanism disappears, and they slip over the edge of hypoxia and acidosis. A lot has been made of the so-called overdose of ketamine. We're not sure. It's still an open question, but there are some pretty significant studies which suggest there's a study looking at kids in hospitals that got overdoses of ketamine 20 to 50 times what they were supposed to get, and nobody suffered any harm at all. It doesn't appear as though ketamine is toxic at high doses, and the overdose, when we say that, really probably what happens is they just stay unconscious for longer. It's the way the ketamine is being used. So if I'm telling you it wasn't the ketamine that killed James Britt and Elijah McClain, what really did kill them? And I want to be super clear again, I'm not a forensic pulmonologist or pathologist. I'm not going to pretend I know the definitive answer to those very important questions. But we have a pretty good idea. Positional asphyxia due to prone positioning with weight on his back or side for an extended period of time. While he was restrained on the ground, his fight or flight sympathetic surge was keeping him breathing and alive. Ketamine obliterated that sympathetic surge. As a consequence, he could no longer maintain his drive to breathe. He was held down for 2 more minutes and unconscious, and then shortly thereafter in cardiac arrest. There are other possibilities if we want to get into the fine points of the pathophysiology. We do know that if you give ketamine rapid IV push, it can cause apnea. We don't think that happens with IM injections, but with a large enough IM injection, could that act like a rapid IV push? Maybe, we don't know for sure. And it's also possible, and I'll show you exactly what I mean, that ketamine had nothing to do with their deaths, that they died from positional asphyxia alone. I told you at the beginning I don't know the answers. One answer I do know, I want you to write this down and take it home. Prone positioning for an extended period of time is inherently dangerous. This is especially true with any weight on the patient's back or side, with their hands secured behind their back, or with alcohol or drugs on board. Now, don't get me wrong, prone positioning is sometimes necessary by law enforcement or even by us to gain control of a patient. It's often the most effective way to gain control. The danger lies in the decision to keep the patient in that position once immediate control has been established. This is Dr. Martin Tobin. He is actually an expert ICU physician, pulmonologist, and physiologist. He testified in the trial of Derek Chauvin, which Derek Chauvin was being tried for the death of George Floyd. We're not going to talk in depth about George Floyd, but I want to share a couple of clips from what Dr. Tobin said during that trial. Dr. Tobin was asked what caused the death of George Floyd.
Mr. Floyd died from a low level of oxygen, and this caused damage to his brain that we see, and it also caused a PEA arrhythmia that caused his heart to stop.
Is this what some persons might refer to as asphyxia?
Yes, it has been called asphyxia. To me, it's not terribly helpful. It just, what we're really talking about is a low level of oxygen. Other people talk about hypoxia. That again is just a Latin term meaning a low level of oxygen.
Have you formed an opinion to a reasonable degree of medical certainty as to what the cause is or was for the low level of oxygen in Mr. Floyd?
The cause of the low level of oxygen was shallow breathing. Small breaths, small tidal volumes, shallow breaths that weren't able to carry the air through his lungs down to the essential areas of the lungs that get oxygen into the blood and get rid of the carbon dioxide. That's the alveoli at the bottom of the lung.
He's asked what caused Mr. Floyd shallow breathing. He responds that he was prone on the street, hands rammed into his back, knee on his neck, knee on his back and side. Air couldn't get down into his lungs. George Floyd's last words were, "I can't breathe," and Dr. Tobin is next asked, are those words significant to you as a pulmonologist?
Those words significant to you as a pulmonologist?
Yes, I mean, obviously they're important different ways. One, he's complaining to you of difficulty with breathing, but they're also telling me that at that time when he's saying, "Please, I can't breathe," we know at that point he has oxygen in his brain. And again, it's a perfect example of how it gives you a huge false sense of security, because very shortly after that we're going to see that he has a major loss of oxygen in the way that he moves his leg. And so it tells you how dangerous is the concept of if you can breathe, or if you can speak, you can breathe. Yes, that is true on the surface, but highly misleading. A very dangerous mantra to have out there.
Fascinating. I've said in similar circumstances, "Hey buddy, if you can talk, you can breathe, I'm pretty sure." It turns out that's not really true. Yes, you do need to be moving air by your vocal cords to create speech, but the amount of air you need to move by your vocal cords is very low in comparison to what you need to do to prevent yourself from becoming hypoxic. And Dr. Tobin says the mere fact that he's conscious one moment and speaking doesn't mean the next moment he might not precipitously deteriorate. There's been prior research, conflicting reports on the dangers of placing a patient in the prone position with weight on their back or side. There's some research that has seemed to suggest that it wasn't, but that research has now been called into question. It was research done on healthy young volunteers, weight on their back or side for a period of time, and not surprisingly, they didn't run any of the research out to the point where any of them died. So if it in fact works like a cliff phenomena where they appear okay until the moment they catastrophically deteriorate, not a big surprise that research didn't tell us about the problem. And I'm going to skip this, but Dr. Tobin directly addresses that, saying that the studies are irrelevant to the situation that we're faced with here, that you can measure oxygen saturation, say with a pulse oximeter. It can actually look pretty good until the moment when it doesn't, and then it could decline precipitously. Here's what it looks like, right? We've all seen this curve from EMT or paramedic school, and that's exactly what's happening. We don't deteriorate, patients don't deteriorate in a linear fashion. When it comes to hypoxia in these scenarios, they look okay until they reach a point of decompensation. fascinating to me when I watch, because I've watched a lot of these videos, there often is a crucial moment, and I'm going to show you 2 short videos, where one of the police officers says to the other police officer on scene, hey, I'm worried about this guy. I think we should roll him up on his side, and, well, I'll show you what happens. The first is from George Floyd. Officer Lane says that to Officer Chauvin.
Roll him on his side? Okay. I just worried about the delirium or whatever. Okay, that's false.
So Lane is a junior officer recently out of the academy. Chauvin is his supervisor. Chauvin has decades of experience. And I actually give Lane a huge amount of credit for speaking up and voicing his concerns, not once but twice. He uses excited delirium. Where did he get that from? How do you even know that? Well, he's recently been in the academy, where they warned him and the other officers in his class about the dangers of prone restraint. And so you see sort of a push-pull between Lane saying, hey, I'm worried about this. This is what they warned us about at the academy. And Chauvin saying, no, he's staying right where he's got him. EMS will deal with it when you get there. This is Mario Gonzalez. Mario Gonzalez unfortunately died in April 2021 in Alameda, California. Mario was hanging out in the park. He's definitely on something. I'll play you a short clip where you see police interacting with Mario, and then a clip of him restrained on the ground. Again, no criticism. In fact, I think the police here were just trying to get Mario to help, get him to the hospital, get him out of the park, and things unfortunately went wrong.
Mario, right? Was it Mario? No. Hey, do me a favor. We're going to stand over here, okay? There's something here. Hey, come over here. Come over here. We don't want you to fall down, okay? Yeah. All right. Do me a favor. They're getting wet. We're just going to put your hands behind your back. I got it. What? You got what? No, wait. It's wait, what? Hey, Mario. Heck? Hey, Mario, walk with me, okay? Please, stop.
And you'll note in both these cases, in the case of George Floyd and the case of Mario Gonzalez, there's no ketamine. EMS isn't directly involved. There's no sedative at all. I'll now play the clip, and I will pause it as we go along to point some things out to you.
Mario, calm down, please. Stop kicking, Mario. Stop.
So they've got Mario on the ground. Mario's a big guy, right? He's got that problem of obesity again, that large pannus pushing up on his diaphragm. He also has probably something on board. I don't know that for certain, but I suspect that's the case. And when they get him down on the ground like that, and they're holding him with his hands behind his back, did you hear his breathing? It almost sounded like grunting, right? Why is he grunting? He's grunting at, what is that? That's PEEP. He's trying to maintain an adequate tidal volume. He's trying to keep his lungs expanded so he can breathe. In every single one of these videos I watch, the police officers say to the subject, sir, just calm down, stop struggling, and we won't have to do it this way. Can any of these individuals not struggle? Absolutely not. Why are they all struggling? Does Mario want to get up and beat the crap out of cops? Not even in the slightest. Mario wants to get up and breathe. Mario feels hypoxia. He feels in his brain the onset of a precipitous decline in his oxygenation, some developing acidosis, and his brain is telling him you have to get up and breathe.
Stop kicking. Think we can roll him on the side?
I don't want to lose what I got, man.
Okay.
Can you grab the wrap out of 111?
Mario, just please stop fighting us.
It's all right.
We have no weight on his chest.
Can you go around, man?
No weight.
He's going on sponsor.
Copy you.
Mario.
910 can slow down.
Mario.
Unfortunately, Mario is not gone unresponsive. Mario is dead. They do the right thing. They immediately roll him over. They start doing CPR. They immediately call for EMS. EMS comes and makes a valiant attempt to resuscitate him, but they're ultimately unsuccessful. What else did we see in the last part of that video? You heard one of the police officers say to the other one, hey, you think we can roll him on his side? And the other one says, no, I don't want to lose what I got, right? Again, you see that tension. And we need to be that part of the equation coming in there because they're both jacked up, right? Their job is to gain control of the situation. Our job when we show up on scene is medical care, and we might be that independent voice who can come in and say, hey, we really need to roll him up on the side, we really need to get him up. The last thing you saw of significance is, he says, hey, we've got no weight on his back or side. Why does he say that? Because it's 2021, this is post-George Floyd, and they're very aware of that issue, and yet it's pretty crystal clear in the video that there is actually weight on Mario's back and side that has the same impact as though they were right squarely in the middle of his back. James Britt and Elijah McClain are not alone. Those are the ones that often get a lot of media attention, but the reality is there's been 6 or 7 or 8 individuals who were treated by EMS, had received ketamine for sedation, and ultimately died under somewhat similar circumstances. So what now? What do we do? How do we, because the title of this talk was that I was going to tell you how to avoid some of the major pitfalls. That's what we're going to talk about now. I actually think after having spent a lot of time talking to experts, looking at many of these videos, looking at the research, there are 10 key principles that need to be implemented in order to, and I'm not going to say make it safe, because physical and chemical restraint are inherently dangerous, and we're constantly, as providers, exercising our judgment. And I certainly am not going to suggest that we don't sedate people. I have ketamine on my Intercept vehicle. I've used it to sedate patients. I think if we understand the risks associated with it, it can be used safely. But I think that we need to implement some of these principles. And I will tell you that in New Hampshire, where I'm from, we've recrafted our restraints protocol around these 10 principles. Principle number 1, prone restraint is inherently dangerous. Never, and I don't use that word lightly, never restrain a patient in the prone position for an extended period of time. It creates a severe risk of ventilatory compromise that results in hypoxia and acidosis. Death can occur suddenly and with little warning. We just saw it happen with Mario Gonzalez. Number 2, only proceed with chemical restraint if the patient at the moment you decide to inject them is an active threat to self or others. I think we did paramedics a disservice when we told them that anytime a patient is physically restrained, they should be chemically restrained for their and our safety. I'm not saying never do that. What I'm saying is, like so much of what we do, it requires that you exercise your judgment. Someone who's mildly agitated, the balance might be to decide to just physically restrain them if you can do that safely. Someone who's truly out of control and thrashing, that individual needs to be chemically restrained. But the determination should only be made after attempts at de-escalation have been unsuccessful, and a patient, I would argue a patient who's physically restrained and is not actively fighting is not in active danger. And in so many of these videos I watch, at the time, there for sure have been agitated patients, including those who struggle with police, but at the time EMS injected the sedative, quite often they're now sedate and cooperative. Number 3, never administer chemical sedation at the direction of law enforcement. A lot has been made of the fact that in the case of Elijah McClain, they specifically requested EMS to the scene for sedation. I think it's clear to most of us that the decision to administer chemical sedation is a medical decision made by the provider based upon clinical judgment alone and should not be influenced by the police or anyone else. I say that, and there's another video I show where the paramedic shows up on scene and gives the ketamine, and a lot of people are like, why'd she give him the ketamine? He looks pretty calm. And what you have to do is watch the whole video and recognize just how much energy was around the wrestling match that the police had with this individual, and EMS is coming into that already charged scene. So I think it's easy for us to sit in a room and say that, harder to do when you're out in the field. Number 4, before proceeding, identify and treat any potential organic causes of a patient's combativeness. Combativeness may be due to medical conditions or due to hypoxia, hypercarbia, hypoglycemia, drug and/or alcohol, drug overdose, or brain trauma. Number 5, beware unconscious and anchoring bias. Implicit bias, which we didn't have time to talk about today, but occurs when our unconscious assumptions negatively impact the care we provide. In the case of Elijah McClain, when EMS showed up, police said to him, hey, he's got superhuman strength, he's pouring sweat. Elijah McClain weighed 140 pounds and was taking 3 police officers to hold him down. And so the police intimated to EMS that he was on, they even said he must be on something. Elijah McClain hadn't taken any drugs that day or any other day. He was exhibiting that superhuman strength because he was fighting for his life. It is the greatest and unconscious anchoring bias. Anchoring bias is we show up and we're told something by police. Hey, this guy's out of control. He needs to be sedated. You know, get the paramedic, get the ketamine. We need to get this done. We always need to take that step back and do our own evaluation. Just like when we show up at the hospital and we give the physician the perfect report, we've figured it all out, we've done our investigation, our assessment, and we basically hand it to him on a silver platter, and then the physician looks at the patient and says, so what's going on today? And you're thinking, you jerk, I just told you what's going on. He's doing the same thing I'm asking you to do. He's got a duty to conduct an independent assessment, even if he believes what you've told him. Number 6, consider an alternative agent. Ketamine is intended for severe agitation. Droperidol is a drug that is coming back and being added to EMS restraint protocols. I have not personally used droperidol, but a number of agencies, including some here in Texas, have added it back to their protocols. It's an agent similar to Haldol. It's an antipsychotic agent, and it's being viewed as sort of an intermediate agent between maybe a Versed on the low end for your mildly agitated patient, droperidol somewhere in the middle, and ketamine for those super agitated patients that are in active danger. Number 7, never, and I use that word again purposely, never administer chemical sedation to a patient in the prone position. You saw the paramedic give the ketamine to James Britt while he was being restrained in the prone position. I think just like when we do RSI, we have to resuscitate before we intubate. Here we need to reposition before we sedate. So reposition the patient to ensure airway and breathing are not restricted before proceeding with sedation. Administering ketamine to a patient restrained in the prone position carries a profound risk of death. I want to say one other thing right here, and that is I keep talking about the prone position. Really, any position in which their breathing is restricted is potentially problematic. Number 8, all monitoring and resus equipment must be at the patient's side before proceeding with chemical sedation. This includes equipment to monitor heart rate, pulse ox, etc., and oxygen nasal cannula, non-rebreather mask, and anything you might need to resuscitate that patient. I'm an RSI paramedic. If I'm going to take someone's airway, I'm going to paralyze them with rocuronium. Before I ever do that, I conduct an assessment. I have my monitoring equipment all right there. And before I push that paralytic, I've thought through not only the intubation, but plans B, C, and D, and what could potentially go wrong. And everything I need if something goes wrong is right there by my side. I don't think after the fact, while I'm RSIing somebody out on the street, oh, hey, go grab that bag valve mask, we might need it. Number 9, during sedation, the provider must be laser focused on monitoring the patient's airway, breathing, and circulation. Treat chemical sedation like intubation. Once I take that patient's airway, I'm then laser focused. The rest of the world could be disappearing around me, and I'm just going to stay focused on the patient's airway and breathing. If you're going to sedate someone with ketamine, it needs to be treated in the same way. Both are high-risk procedures that require providers' undivided attention, and apnea can occur suddenly and silently. I've shared with you some cases of deaths. I've talked to many paramedics at this point, because I've done this talk quite a bit, who've told me there, but for the grace of God go I, that they had an intoxicated patient who was agitated, who they gave ketamine to, and they turned around for a moment and turned back and realized the patient had become apneic. And what's happening? The risk is enhanced when they're intoxicated because the ketamine again takes away that sympathetic surge, and now you've got unopposed sedation from the alcohol. And number 10A and 10B, I actually had 11, but I wanted to keep them to 10. So 10A, obese patients are at increased risk of apnea. Their weight exacerbates breathing difficulties. And 10B, alcohol and or sedative drugs create a severe risk of apnea. Chemical sedation eliminates a patient's sympathetic drive, leaving the depressive effects of alcohol and sedatives unopposed. I'm going to show you one more video, but before I do, so what should you do with those? I think the answer is that we need to reassess how our protocols are constructed, how our training is constructed, and how medical direction leadership is provided when it comes to the use of physical and chemical restraint. And I truly believe those principles, or some version of them, should be incorporated into your protocols, into your training materials. And by the way, yes, anybody who wants to can email me and I will send you all of these slides. My goal is to disseminate this and actually turn you all into evangelists to go back to your departments. I gave a similar talk last year and shared with a number of physicians and others my slides. This is Trey Ellinger. He died, well, July 2023 in Baltimore. And I'll be honest, when I first watched this video, one of the thoughts, and you'll see it, oh, these folks have had some training, because you're going to hear them say, don't put them in the prone position. And my first thought was, that's great. They've had some training. Here's the problem. I think they got the piece of don't place the patient in the prone position, and you'll see how things go wrong. But I think it's not enough to focus just on that positioning. I think it's a mistake to do that. I also think it's a mistake to focus just on monitoring after the sedation. I truly believe you need to have the whole package correctly done in order to make this as safe as possible. So let's watch this and then I'll talk a little bit about it. First, I'll show you the police interaction with Mr. Ellinger.
Yeah, they said they want to try to sedate him because he's going around on the ground. Like he's going right now. He's going around.
Yeah, y'all
you see something, but not there.
Hey, Bobby.
Go.
What meds did you take, man?
What you take today?
Just stay still.
Stay still, man.
Oh, they're playing up, Johnny. They might hear pistols.
Hey, relax.
Relax.
It's okay. Calm down, bro. It's all right. Calm down.
That burns.
Who's mad?
Yeah, it's really.
You want to put on the front?
Man, I forgot.
No, I know because he. Hey, what's your name? All right, listen. We got to put your arms back.
Calm down. How did that happen?
All right, the other arm.
Get the other arm.
15 of me.
It's okay.
Calm down. Calm on. It's okay. It's okay. Help him with the other arm. You're fine. You're fine. Thank you. Thank you. Thank you. Thank you, sir. Thank you. Thank you. You're good. You're good. Thank you. Thank you, sir.
Yeah, that's fine. We're just gonna hold him right here. They're gonna
hold him right here. Let's just put him in recovery. Don't put him in recovery. Turn over. Turn over. Come on. Turn your head. Hey, what's wrong with you?
He took something.
He said hold him so they can give him the meds. He's still gonna go off.
What?
Keep him right here. We don't want. Yeah, I got you. We just don't want him face down. Okay. Stop trying to move. Stop trying to move.
So how did they do? They did pretty well. I actually think they were pleasant. They weren't being unkind. I think they were trying to get him prepped for EMS so that he could receive appropriate medical care. And one of the things they recognized is as soon as they handcuffed him, they needed to get him up on his side. So they were alert to that problem. It's interesting. I showed this video to a group of firefighter paramedics, and one of them had an interesting comment. They said, did they even need to handcuff him? He was on the ground. They had enough police officers effectively keeping him safe. Couldn't they just have picked him up and put him on the stretcher like that and then restrained him to the stretcher? And I think that's an interesting comment. But overall, if I had to assess the police officer's response here, I think they did a reasonable job. Here's the EMS piece of the equation. And again, I want to be super clear. I'm not judging Baltimore Fire or the paramedic involved here. All I have is the video. I don't have PCR. I don't have an autopsy. I'm not going to show you what came before because we just don't have that footage. But watch now in the context of what I've already shared with you of the things I think you need to do to make this as safe as possible. I'm going to ask you afterward what your thoughts are.
Yeah, where's my goal at? Why are you playing now?
Yesterday.
I lost it. But no, I don't want to say that. I do not want to say that.
Our understanding is that's ketamine. I don't have definitive confirmation, but it mentions ketamine on the scene.
It'll help.
All right, sir. It's okay. We're here to help you, darling.
Yeah, just kind of put him in a daze. Okay.
This is his, right?
Yeah. That's what you say? All right. It's not going to change for about the next 4 minutes, but we can start moving if you like. It's up to you guys.
Wait, you killed all the smoke.
At least y'all got
Stop fucking out of me.
All right, so As long as he's not laying face down like a bird.
Yeah. Well, he's. Do you want to lift him up? I'd rather get him up here if y'all can.
Nah, if you wait 4 minutes, it's going to let 4 minutes kick in. We're going to keep spazzing. All right, so y'all want to pick him up? All right, 1, 2, 3.
Oh, God, it sucks. Oh,
jeez.
It's okay.
It's okay, sir. We're trying to help you, okay? We're trying to help you, okay?
I don't know what that is, bro. It's like apple pain.
It's okay, darling. It's all right. It's okay.
It's all right.
It's all right.
If I pick up,
they're like 6
Yeah, absolutely. All right. Absolutely.
Okay, Merlin check. Bob, DM 526.
Am I riding with the knife or just follow?
No, you ride. You get your vehicle. I'll ride.
So he's loaded in the back of the ambulance. He goes into cardiac arrest a short time later. And again, the story is the same as the rest. He ultimately dies from a anoxic brain injury. In watching this video, and I don't know if you could hear it, the paramedic says at one point, I just don't let him go prone. And yet, what position is he in when he enters the ambulance? He's prone, right? What happens? They put him on a stretcher on his side, and he kind of kibbies down until he's prone. And then you see the paramedic kind of ratchet down the strap, and he's not being a jerk. He legitimately wants to protect the patient from falling off the stretcher, because that's a legitimate concern, and yet tightening that strap across his lower back was probably, and I don't know for sure, a significant piece of the equation that led to Mr. Ellinger's death. So let me back up a little bit. We see the paramedic show up with the ketamine in his hand. Did you see the monitor he had there to conduct his assessment? Did you hear him asking questions? And again, there was, it turns out, a EMS supervisor on scene before this took place, but if I'm the paramedic showing up and I'm going to give ketamine, hey, who is this that we're treating today? Do we know anything about his medical history? Is there anybody here who knows anything about Mr. Ellinger's medical history? What could be going on here? He probably is on something. Could this also be he took too much of his psychiatric medication? Could it be that he didn't take his psychiatric medication? Could it be he got in an altercation, this is head trauma? Yes. So I didn't see any assessment being done. I didn't see any vitals being taken. And then the failure to bring over the monitor beforehand, he injects the ketamine, and then he sort of steps back and he's chatting with the police officers, and he does not have laser focus on this individual who he's just given a very powerful sedative to. They get him up on the stretcher. There, as I said, there's no monitor. There's no resuscitation equipment right there. And he says, let's keep him on his side, and yet he ends up prone. And I'll be honest, after I watched it a couple of times, the part that bothered me I couldn't quite figure out is why, since he knew he didn't want him prone, someone had clearly done training with this EMS agency to say prone is bad, and yet he lets the patient stay prone into the ambulance, and then it clicked. I knew immediately what he was thinking. He was thinking, you know what, I'll just fix it when I get in the bus. Right? The bus is right there. It's literally 15 feet away. I'll just sort it all out when I get there. And the mistake was not recognizing that things could go horribly wrong, even in the time it took to load him into the back of the ambulance and for the paramedic to climb into the back and finally connect Mr. Ellinger up all to the monitoring equipment. Right? This is why I say, why this video worries me is I feel as though agencies are aware of this issue and are doing training, but I worry that the training they're doing is incomplete. They're focused on one piece of the equation instead of the entire equation, how to make physical and chemical restraint safer. So that's all I have for you guys. Thank you very much. I hope this has been helpful. I know this is a difficult forum for asking questions, so I'm going to stay up here after we formally end. If anybody does want the slides, feel free to reach out to me. I also have many of the source materials that are the basis for the thoughts I've shared with you here today, and I'm happy to send folks links as well. Thank you very much.